طيب. So, I'll be fast, guys. Forgive me because we have a limited time. My name is Monief Eid. I'm an e-health senior consultant working for Minister of Health in Saudi Arabia. I have a 30 years experience. You can find me on LinkedIn. I've been through this industry long time. I hold bachelor degree in science biochemistry and bachelor degree in science, a master degree in healthcare informatics. No conflict of interest except those images and pictures, and they are not funded. So I will start quickly with a simulation. There is a lady driving in the park, hard way, and she did a car accident. Immediately, they evacuated her to the hospital, CT full body. But as you can see from the CT full body, there is some clotting, some fraction, some suspicion. So the focus on recover the bleeding, recover the lady, and then in 2 weeks, because the CT shows some suspicion about the breast, they brought her again. And unfortunately, moving from modality to modality till the biopsy, so the case was positive, unfortunately. Taking in consideration the previous image, the clotting, 3-4 weeks or a few months later, she had another cardiac implication. So we took her to cath lab, echo, Holter, and so on. So how many images we did in the 3-4 months? At least 15. And these are real. In any hospital, you will find 20 to 30% of your patients, they have at least different 20 to 25 different images. And those images, they are not alone. They have a clinical content, they have a report interpretation associated to that one, they have some history in the EHR, they have a genomic, name it. It's not only picture, okay? The first view is the picture and the report, but there is a big behind. So we're not different of the world. The others, they suffer from those top challenges when it comes to image and image exchange, interoperability on the level of data source or on the level of exchange or building the bags. Infrastructure, name it, bandwidth, cables, network, and so on. Governance, how to bring those 5-6 different ologies on the same table. They have different workflow, they have different interests, and how they can talk to each other. Patient identifier, this is a pain. Okay, that's a big pain, really big pain. How to have a single source identifier for your patient. And last but not least, security, privacy. Those information belongs to the patient. We cannot break it. So we're not different of the world. We face all of them. Now, before I start with this, in Saudi, those specialty like radiology, cardiology, oncology, dental, I would say they are rich. What I mean rich? They have enough budget, they are relaxed, they buy always the latest equipment. You go to those hospitals, you will find CT 500 slides, you will find BioBlane, cath lab, seriously. And those modalities are digital, and they come also with a workstation and software. So there was a big demand, okay, from the beginning, from those specialty to have their image exchange, to have their PACSs. In other side, our national project EHR, which they call it Nafis today, was delayed, postponed. So that pushed us when we start the eHealth project for imaging, because we want to keep those data, and they will not run together. So we build it based on a multi-affinity domain. Radiology, they have their PACS, VNA, and federated. Same to the cardiology. And I'll show you that. It's working in live, but if we pay attention, or if our EHR run earlier, we could save that, and we could have one, and that's, I would say, lack of governance, okay? Nothing wrong with a multi-affinity domain. So in a brief about Saudi, MOH, the big part, which deliver the health service in Saudi for free, okay? Citizen, they are obliged to have cover that. More than 20 million Saudi. let's say another 10 million foreigner, 30, 35, but we are covered by insurance, so we are treated in a private sector. And they are moving from MOH as a public to a private sector. That's a long journey. It would not happen in 5 or 10 years, because by constitution, Saudi citizen, they are eligible to have healthcare and education free from the government, okay? And here for some numbers about volume of studies. Radiology, we do more than 10 million studies per year, 2 million slide pathology, 0.5 million cardiology, and more than 1 million for dental. So like any other country, we've been through a journey. The Hospital Information System, or EMR, that deployed today 95% across 300 hospitals and deployed across 2,000, 100%. So from EMR, they did a good job now, but not 5, 6 years ago. There were all these hospitals, and during Charles, because Charles was involved in the early days through GE, where they built up the interoperability and the use cases of Saudi Arabia country. So we established enterprise imaging concept early days. Still we follow that based on HEMS-SIM working group. It's a set of initiatives, and you need to have a good governance to ensure those images. I call them in the 8 events, okay? The next slide. In those 8 events, starting from capture, index, process, distribute, and view, to be sure they are in a synchronization, following the standard, okay? They are not, but again, those devices, you cannot grant them, because some of hospitals, they still have old version of modalities. And these modalities are big investment. You cannot throw cath lab because it's a 5 years. You cannot throw a hemodynamic because it doesn't support the HL7. You cannot throw 100 ECGs, just 3 years purchase, and the guy who signed the contract missing the DICOM work less, and name it. Anyway, so that's a conceptual idea. Each ology has their registry, their repository, their bags. Sometimes we have multiple bags, like in radiology. We have 6 vendors, okay? In cardiology, we started with 1, we end up now with 2, and so on. And they need to talk to each other. The framework is an IHE. We are not inventing the wheel or creating any new standard. And of course, the viewer, with each modality, if we buy VNA, definitely the zero footprint is there on the top. If we buy just in a bags, we buy a DICOM viewer and WADO web viewer, okay? And both, they are synchronized. Now, if start with the first project. That's 5 years ago. We renewed the service contract, was with Philips. We call it TAGI 1. We started with the 10 cardiac centers. So what we did, built up 3 systems inside the cardiac center, 50 to 70 beds, just cardiac center. 3 systems, CVIS, very specialized, ECG data management, and cardiac bags, all integrated together with each EMR or HIS if it's available. In some cases during that time, there was no HIS 5 years ago. And all 10, they are connected to one VNA. And this VNA sit in the virtual hospital. In the virtual hospital, there is a cardiology community. So they discuss every day, they retrieve every day the cases, echo, Holter, cath lab, whatever, and they decide about it. And again, it's just the challenges we have faced, but we're lucky again because we have a budget. The modality, you can see this modality on this side, it supports the DICOM more class. So on the VNA, lovely, you can annotate and play with the ECG. The other one, I call it ugly, dead. It's a PDF, okay? So there's 2 ECG cards. If you are not assured that your source of data really fully compliant and integrated, you will end up having the PDF. If you ensure that your ECG card, and that applies to not only ECG card is one example, cath lab, hemodynamic, EP, echo, all those medical devices. So what I'm trying to say here, source of data should start compatible and interoperable. And that's not easy, it costs money. Trust me, in that project, 5 years ago, we end up replacing 390 medical devices, but they have money. And not all the countries, they have the same, okay? Next. That's another example of the data source from the hemodynamic. The one does not support, and you know this structured data, you need to be sure you transfer it and you label it. So Philips, for example, because the vendor is Philips. So they were able to label this and export it to your final report, okay? Another challenge, those cardiac centers, they don't live alone. They are part of campus. So they order CT, MRI, X-ray. How you can differentiate, this is the static for cardiology and this is for radiology. And the modality can accept only one work list. So we end up buying that black box. I call it black box. It's like in a gateway. So they can manage 2 different codes, 2 different work lists in the same time. If you don't pay attention to this, oh, you will stuck while you do deployment, okay? Then we, of course, if you remember the first 2-3 slides of Charles today this morning, use case. This is like a music. You need to memorize it here. You cannot do this business without use case. Use cases tell you who is who, who's requesting, who's sending, who's reporting, who's retrieving, and those rules, okay, convey in the back end, you don't see them, but there are some messages in behind. For example, Hospital A, I did a study, I send it to local server, copy will go to the central, Hospital B, okay, for some reason, second opinion, they have the specialized person, pediatric, neonatal, and so on, retrieve that from the central VNA. Those messages are, as the lady from France mentioned, if you remember, ITI, 18, 46, 95. Each message, each actor has certain functionality. So you have to build up this. You have to build it in your RFP. Right. Let's move. Oops. Now, TAGI 2, we just awarded. Okay? TAGI by I mean, it's Arabic word, means artery. So that's why we call it TAGI. TAGI 2, we have 19 hospitals. We did the same, but in 2 categories. We thought those hospitals who refer the cardiology cases to the center, we put them in a cloud, okay? And then that TAGI 2, if awarded with Philips, great, we have one central VNA. But if awarded to another vendor, and that's happened, awarded to GE, they will send the data to the central VNA, okay? With that same 5 use cases we have described in the project just awarded. In the next 2-3 months, project will be kicked off, 2025, by end, maybe first quarter next year, should be live, okay? Now, the second challenge project, that's a crazy project, I call it. It's a dental. You know the dental has its own specialty, even in the anatomy diagram. The HIS does not support that. So what we have 45 or 41 dental specialized center. They take the hit of 75 of the workflow, okay? 75. And they have a lab to build a bridge and make all these mechanical work in the dental world. So we thought, okay, let's buy them DMS, Dental Management System, a charter, buy dental bags, buy the 3D, dental lab tracking system, and connect them to the central hub, VNA. And we ask the vendor, once you deploy that and complete it, your VNA will talk to the cardiology VNA through the XCA-I with a little gateway, okay? So if I have visit, and they have cross relation, because some cases in open heart surgery, the cardiologist cannot do that. He sent you back to the dentist, fix it, or to the oncologist, okay? So what happened? We did the implementation. We are in the middle of the road. I have to be honest with you. Half of the 41 dental specialized center, in total 1,090 dental clinic. So we deployed it in like 500 almost, okay? So we hope by end of this year we complete that specialty. And the challenge, imagine 1,100 dental clinic, and all those sensors inside, they do not support the DICOM. So if I take a picture selfie, how I can find it? I go to the studio. Ooh. So you can imagine the doctor making an X-ray before he starts, and X-ray through the procedure, and X-ray after that. We have tons of X-rays. What we will do? We're lucky because the vendor who provide that was Infinite. I'm not promoting them. They provide the dental bags, they provide the dental VNA, and they provide a little lovely desktop dichomizer. So you take the image, you open it, integrated already, the demographic data is there, and you select the teeth, one click, boom. So today, while I'm talking to you, we have on the VNA, because those little tool, 1,500,000 images, just from those little sensor. When we calculated to upgrade each sensor, that would cost us $3,000. That's crazy. So $3,000 times 1,000, talk about millions. So we negotiate with Infinite, and they have a really good, but again, it's not straightforward. We apply like different 9 ways to integrate those sensors. Sensor with a twin hardware, sensor without twin, sensor with a twin, but they cannot support license, sensor with a twin, can support, but cannot. Jesus, it's crazy. But you have to consider this while you do the RFB. Just skip this one, the accessible, you can go through those challenges. Now, in radiology, we have 2 cases. We have 150 hospitals out of the 300. They have a PACS. Most of them are standalone. PACS and RIS. And by the way, we buy PACS and RIS because the RIS from the PACS vendor, and I'm not promoting that, more comprehensive, better for our doctor for reporting, versus the RIS coming from the EMR side. So they are functioning well. Having said that, Saudi Arabia is a big country. Most of it desert, a rural area, far away, and you cannot find a specialist. So, and as I said, they have a money, they have a CT, they have, I think, 214 CTs out of the 300 hospital, and they have 150 MRI. Believe it or not, some of these MRI, 3 Tesla, sitting there, they have only 1 technologist. Who will do the hell of the report? So that's another layer project, okay, for, we call it teleradiology. Those 70 hospitals are really critical. Most of them, they do not have the radiologist or the right radiologist to make this report. Now, we have awarded, and Charles was involved in early, if you remember, early days in 2011 and 13, we were talking about, doesn't matter how many PACS vendor you have in the cluster, okay? You need to build it based on a standard. You have a master patient index, you have a registry, you have a repository, and all connected in the cluster on one vendor, VNA. Now we talk about the zone. So we have a 5 zone, north, south, west, east, central. So each zone will have one VNA, and those VNAs, they talk to the national VNA, which awarded already. So this national VNA, 2 petabyte, 1 petabyte for our EHR, because unfortunately when they proceed with Orion, they proceed without VNA, okay? And the other 1 petabyte, we split it. Half petabyte for a pathology project, which is another nightmare, okay? Because you need a lot of configuration and adaption, blah, blah. And another half petabyte, another half petabyte for teleradiology. Because the bags, they have their archive in the zone level. So they don't need to migrate this data. They need to migrate or send that teleradiology data. So half terabyte, half petabyte is quite enough for this number of volume. That's I call it nightmare because it's not straightforward. The start from the order, the LIS. And if this LIS separate or this LIS part of the HIS. Second, you have the scanner. Does the scanner support the DICOM work list, a pure DICOM work list, or they write the DICOM their way, okay? And name it. And then, not only that, the steps behind, you see, this is the scanner. This is the scanner. But you have 5-6 steps. Take the sample, stain it, make it clean, good quality, and the adaptation from the pathologist. Till now, the pathologists, they prefer take the glass and look to the microscope. So it's not straightforward, huh? We still deploy that. I think by mid of next year, we will be fine. That time, the 27 pathology will be deployed and integrated with their half petabyte VNA. And again, in the contract is written, those VNAs, they have to communicate. Very clear profile, does not miss. XCA-I with a gateway. Okay, so why IHE? Because IHE is there is a massive work, guys, have been done before us. Like even when I was in the high school or in the university, a lot of people, like a child, attending how many connectathon you've been there, how many lectures you did, how many testing you've been. So those profiles are there. And what I'm trying to say here, don't start from scratch. Don't invent the wheel. There are people who did it before you. Just talk to them. And you have one of the best people today with us who built up many strategies, many standards, many testing. And it's not only technology. There is a governance behind it. So you need someone to legislate this. Some countries, for sharing and integration, they were behind this because the parliament refused to release the sharing of the information, okay? And then the governance, you need to govern between multi-stakeholder. Each stakeholder, they have their own workflow, their values, their interests. You have to create a shared value, okay? And this comes from the top to the bottom, not the opposite. And then you need to do change management and adaptation. You need to train your people, the staff. There is something called health informatics. Not anymore. We need to go one step above to learn those terminology and so on. So it's not straightforward, guys. Okay? And imagine, those are the department, they produce different images and name it. Invasive, non-invasive, upper hand, right, left, in your chest, and the back, on the skin. You can't imagine if you want to build up an enterprise imaging strategy, it's not one box. There are multiple boxes and blocks, and you build them carefully, one by one, okay? I would not spend that time. Here, this is my dream, okay? I was working with a really top talented group, HEMSIM Enterprise Imaging, and for 2 years, it took us 2 years to create this profile. That's what I want to, not me personally, because I'm not a physician, but I want the physician, when they open this page, they can see everything. They can see everything. This profile convert the magic. So you see underneath, underline, the measurement directed to the image. You have the table, show you the progress in the image. So when you click on that link, it will take you directly to the repository. So you have everything in one page. And that's what we call it IMR profile, and multimedia interactive profile. I think next week in Toronto, there are a few vendors are going to test that one. And This will change the shape. This will push imaging vendor to be more productive and see beyond the interoperability and the outcome value. I need to see everything in one page. And by the way, these are real reports, cementing level 7 from Canada, from state. Like, you see the beauty? This is the anatomy part of the cardiac. This is the cath lab. And I'll show you the percentage directed to that. That's a real, okay? But it's happening in a few sites. As per my little knowledge, I know that there are 2 vendors who can support today this feature, but not yet tested with a connected thought. Bottom line, enterprise imaging, sharing is not easy. It's a long journey, and every day you learn something new about this world. With that, thank you very much. Questions? The reason I asked, I remember that. In the virtual hospital, when those cardiologists, they retrieve the image from the VNA, because our VNA is all online. SSD drive is very good. But even though, average time between 30 to 40 seconds, which is acceptable because you're sitting in a virtual hospital, but pay attention for radiology is different. Because sometimes you need these images for a stroke patient. I cannot wait 40 seconds. The stroke is scary. I need to see it in a 5 seconds, okay? So when you told me that 20 seconds, that's really good. And emphasizing this when you talk to Walid in Saudi, if he interested to participate your working group, that this is a key for certain disease, like 20 seconds from the resource and the repository. That's really good timing.
Yeah, if I may add something, one of the reasons why we create a manifest for the studies is because the creation of the manifest happened next to the creation of the images and their reporting. You kind of have time to create the manifest, to publish the manifest. Now, when you have selected a manifest and you say, I want that study, you want to grab the manifest in one transaction, access the content, select a series, launch the WADU-RS request, no time to do some Kido, some fire
I agree.
Dynamic imaging study, queries, all of that. You need to have all of the data in one transaction, and the data needs to pre-exist the need. Otherwise, you are adding time at the crucial time when you need to retrieve the images. So it's an important element in the architecture to not use a dynamic fire study resource, but to use the DICOM class as a stored object because that brings performance. You save 2-3 seconds at the time you consume the image.
Today with the EHR, they send the only image report, HL7. As I remember, the original use case you built for Saudi, you published the DICOM manifest on the national VNA. Unfortunately, they do not have that. But with this award, now by end of this year, they will have 1 petabyte. And I think this is the right.
Okay, but are they creating the manifest associated with those images?
No, not yet.
Okay.
You need to push him. Okay, any question, guys? Sorry, I was fast, but this topic is very heavy, huh? We can spend hours.
What would be your recommendation? Because the thing you've done is you've taken dental images, you've taken
Radiology, cardiology.
You're really into the multidisciplinary, where many national projects in their initial phase radiology only, and then they expand to add cardiology, add dental. Uh, they do the increment that way. What would you say, is that a good strategy to do the ologies one by one on a consistent architecture for all of them? Or is it a dangerous approach to do them one at a time? It looks like pathology, we need to do it anyway as a separate step. We
Pathology.
move to the size of images that are beyond our regular understanding.
There are some factors you need to take in consideration. Number one, if you have really good governance, and those ology clinical people, forget the IT, are talking to each other, you feel they have a shared value, you feel that they go back and influence their user, then you can start with one. But this is maybe in the dream, okay? Because barely they talk to each other in the same hospital. So I would say, no, whoever is ready, okay, whoever has a budget, whoever will to go with you in that journey, even if they are in parallel, like what we did in Saudi, you go for it. But make them in one spot, one VNA, no. I think, and somehow we were lucky that our Nafis national EHR was late, and you want to maintain this data in the future if you want to migrate it. And you stuck with the ID. I have to buy every time XDS, registry, repository, VNA. I know it's a cost, fine, they have money, they can afford it, but I cannot leave this data without a proper interoperable platform so I can communicate them in the future with a national, otherwise you will end up buying DICOM archive.
Right.
Would you do that? Just DICOM?
No, that's not sufficient.
Yeah.